This licensure mastery briefing was developed by Dr. Abdulkareem Iblasi, rnn.iblasi@gmail.com, to prepare you for the cognitive rigors of professional nursing exams.
And I really want you to focus on that word,
Right.
rigor. We're not just talking about memorizing facts from a textbook. We're talking about rewiring how you think.
Exactly. Welcome to the deep dive. Today, our mission is very, very specific. We're taking a huge stack of research, a ton of guides on the next generation NCLEX, the NGN, and all of Dr. Ablasi's strategies, and we are boiling it all down to one central idea.
Mm.
We're trying to bridge that gap between just knowing things, like having a stack of flashcards memorized, and actually thinking like a safe, competent nurse.
It's a massive shift, a
Mhm.
really massive shift. It's moving from what I call student mode to clinician mode. And honestly, it can be a painful shift for a lot of people
Why is that?
because you have to let go of that safety net. The safety of just tell me the right answer. You have to move into this messy, gray area of, well, it depends.
It really does, and the stakes couldn't possibly be higher. We aren't just talking about passing a test to get a job. We're talking about avoiding something the literature calls failure to rescue.
That's a term that just stops you in your tracks, isn't it? Failure to rescue.
It came up in almost every single source we looked at for this briefing.
Mm.
Can we just unpack that for a second? Because historically, nursing was seen, and let's be real, sometimes it still is by the public, as this very task-oriented job.
Oh, absolutely.
You change the linens, you help with hygiene, you give the pill that the doctor ordered.
The old handmaiden myth.
Right.
But the profession has completely evolved. I mean, it is now this complex, autonomous career where the decisions you make, often in a split second, are the difference. The difference between a patient going home to their family or, suffering a sentinel event.
So failure to rescue is what exactly?
It refers to the clinician's inability to recognize those early signs of deterioration. It's not about messing up a code blue when it's happening. It's about missing the 4 hours of warning signs before the code blue ever had to happen.
And that is the whole reason the exams had to change, right? That's the driving force.
It is exactly why. The National Council of State Boards of Nursing, the NCSBN, they knew they had to shake things up and shake them up drastically. Employers were complaining. They were seeing new graduates who were book smart for sure.
They could list every side effect of a beta blocker.
Oh yeah, they could recite the anatomy of the heart backwards.
Yeah.
But employers were deeply dissatisfied with their clinical decision-making. These brand new nurses were just missing those subtle early warning signs. They didn't know when to worry.
Okay, so for our deep dive today, I'm going to put on my lead nurse educator hat.
Right.
I want to look at how we actually learn this stuff so it sticks, not just for the test, but for when you're on the floor at 3 a.m.
And I'll be the pro-metric exam strategist. My job is to break down how to win the game of the exam. Because make no mistake about it, the licensure exam is a game. It has very specific rules, and if you know the rules, you win. If you don't, you can be a fantastic nurse in your heart and still fail.
We have a ton to get through. We're going to dig into the clinical judgment shift and the model behind it. We're going to debate why understanding the rationale is so much better than just memorizing answers.
Every single time.
And we are going to get into the absolute heavyweight champion of the exam categories, safe and effective care environments.
That's the foundation.
Right.
I mean, if you're not safe, you don't pass, period. It doesn't matter how much physiology you know.
So let's start with the logic of it all. The exam changed to the next-gen NCLEX. Why? Why weren't the old multiple-choice questions cutting it anymore?
It all comes back to that word, validity. They had to find a way to measure valid clinical judgment inside a standardized test. With the old multiple choice, you could guess. You could pick C because it just, felt right.
Mm-hmm.
The exam couldn't see your thought process. It had no idea how you got to that answer.
So they needed to see the work.
They needed to see the work.
Oh.
So they developed the NCSBN Clinical Judgment Measurement Model, the CJMM.
I'm looking at the diagrams for this model in our source material, and it looks complicated. It has layers, 0 through 4. It looks a bit like an onion.
It does. But for your purposes, for the exam and for your practice, you really only need to focus on one part. Layer 3. Think of Layer 3 as the engine of the new exam. It has the 6 cognitive skills. If you can master these 6 steps, you will master the case studies and you'll master the floor.
Okay, let's walk through them one by one. This is the core of how they want you to think. Step 1 is recognize cues.
Right. And I want you to think of this as the detective phase. You walk into a room or you're looking at a patient's chart on the computer screen and you were just bombarded with data.
It's totally overwhelming.
It is. Vitals, lab results, patient history, what the patient is saying, what the family member is yelling. Recognizing cues isn't just about seeing it all, it's about picking out the relevant data from all that clinical noise.
The sources had a really good example for this. A patient admitted with pneumonia.
Okay, let's break that down. So the chart might say the patient has a history of arthritis, or that they wear glasses, or they retired 5 years ago. That's noise. It doesn't matter for the immediate crisis.
So what are the cues?
The cues are the temperature of 38.6 Celsius, the heart rate of 110, the oxygen saturation of 90% on room air. But it's also the subtler stuff.
Right, like the nurse's note that says, patient reports feeling dizzy when standing up, or skin is warm and flushed.
Exactly. On the exam, a recognized cues question will literally ask you to highlight the data that matters most right now. You have to ignore the arthritis history to focus on the signs that are screaming sepsis or hypoxia.
Okay, so that leads us right into the second step. Analyze cues. We've got our data. We've highlighted the scary stuff. Now what?
Now we connect the dots. We have to move from what do I see to what does it all mean? This is where you start linking those cues together. So in that pneumonia case, you have a high heart rate and you have low blood pressure. If you just look at them separately, you might miss the big picture.
Right, a high heart rate could just be from pain. Low blood pressure could be, I don't know, a side effect from a medication.
But if you link them, low BP plus high HR plus a recent surgery in their history, now you're not thinking dehydration. You're thinking shock. You're thinking potential hemorrhage. You are synthesizing the data to see the underlying pathology.
This is where I saw a big warning in the notes about something called anchoring bias. That sounds like a psychological trap.
It's one of the biggest cognitive pitfalls for new and experienced clinicians. Anchoring bias is when you latch on to the first piece of information you get and you just can't let it go.
So, for example, a patient comes in with a broken leg. I'm anchored on broken leg.
You're anchored, that's the label. So later when they start complaining of some chest pain or they seem a little short of breath, your biased brain says, oh, it's just anxiety from the pain.
Because I'm stuck on the orthopedic problem.
You are totally stuck. And if you ignore that later evidence, the new confusion, the little petechia on their chest, you miss the fat embolism. Analyzing cues means you have to look at the entire picture and actively fight that urge to stick with your first impression. The exam will bait you with this constantly. They'll give you a distracting history to see if you'll ignore the new acute symptoms.
Which brings us to step 3. Prioritize hypotheses. This feels like the triage part of the process.
Yeah, it is absolutely the triage step. You're ranking the problems. A patient will almost never have just one thing wrong. You have to decide on urgency, likelihood, and risk. The question you have to ask is, what is going to kill my patient the fastest?
I liked the example they used of the hip fracture patient. Let's play that one out.
Okay, so you have a patient, let's call her Mrs. Higgins. She has a hip fracture, and she's reporting 8 out of 10 pain. That's a big deal. We are nurses, we want to treat her suffering. But when we look at the cues we analyzed, her chart also says she has a history of heart failure. And right now, her breathing sounds a little labored, and you hear some crackles in the bases of her lungs.
So prioritizing hypotheses means I have to decide. Is the pain what's driving her vital signs? Or is that history of heart failure actually getting worse, turning into fluid overload?
Right, and which one's going to kill her first? Pain is awful, but fluid filling up the lungs is fatal. So you have to prioritize the hypothesis of acute decompensated heart failure over the hypothesis of acute pain. You have to be ruthless about it.
And that decision then dictates everything in step 4. Generate solutions.
This is your plan of attack. You've identified the killer problem. So now what are your expected outcomes? And here's a big strategist tip. What specific interventions are indicated and what interventions are contraindicated?
Contraindicated is such a key word there. The exam loves to trick you with answers that sound nice in general, but are actually dangerous in this specific situation.
Absolutely. Let's say you have a patient with appendicitis. Applying a nice warm heating pad sounds comforting, right? It's basic care for a tummy ache. But in the context of appendicitis, it's strictly, absolutely contraindicated. Because the heat increases blood flow to the area, which could cause the appendix to rupture. And then you have peritonitis, which is a disaster. So generating solutions is not just brainstorming nice things to do. It's a really rigorous filtering of what you must not do.
It's about setting the boundaries for safety.
You got it. You're defining the plan.
Okay, then step 5, take action. This seems pretty straightforward. You just do the things on your plan.
It's the execution phase.
Yeah.
You're monitoring, you're teaching, you're giving meds. But here's the strategist note on this one. Avoid textbook rigidity. You have to consider the specific context. What resources do you actually have? Is there a time pressure? Are there cultural needs to consider?
The notes call these level 4 factors, things like hospital policy or the environment you're in.
Right, if your plan is give oxygen, but you're stuck in a hallway with no wall hookups, take action. Means you have to go find a portable tank. The exam tries to simulate the messiness of real life. It's testing if you can adapt the perfect textbook answer to the situation you're actually in.
And that brings us to the final step, step 6. Evaluate outcomes, the feedback loop.
Did it work? It's that simple. You compare the observed outcomes to the expected ones. If you gave the pain medication, is the patient's pain score down? If you gave the oxygen, did their O2 sats come up?
And what if they didn't?
Then the cycle doesn't end. This is the crucial part. It repeats. If the goals are not met, you go right back to step 1. Recognize cues. Why didn't it work? Did I miss a cue earlier? Is there a new cue now? Did the patient's condition just change on me?
You know, it's so interesting to compare this to the old way we all learned nursing, the nursing process, or ADPIE.
Assessment, diagnosis, planning, implementation, evaluation. Yep.
ADPIE isn't wrong, but this feels different.
It's not wrong at all. ADPIE is still the foundation. But ADPIE can feel very linear. You do A, then D, then P. It's like climbing a ladder, one rung at a time. The CJMM is iterative. It's a circle. It acknowledges that while you are implementing, you are also assessing. While you are evaluating, you're already generating new hypotheses. It's dynamic, just like a real shift on the floor.
It really hammers home that thinking like a nurse is not a straight line.
No, it's a web. It's a spider web. And when you touch one strand, the whole thing vibrates. And that is exactly why this next topic is so critical. You cannot memorize a web. You have to understand the logic that holds the whole thing together.
Let's get into it. Rationales over memorization. I see so many students who just do thousands of practice questions. They do them until their eyes bleed, they get an answer right, they get that little dopamine hit, and they immediately move on to the next one.
And that is the single biggest mistake you can possibly make. It's what we call the illusion of competence. You feel like you're learning because you're just recognizing patterns in the questions, not the actual medicine behind them.
So why is that such a dangerous trap?
Because the exam doesn't test your recall. It tests your ability to apply knowledge. If you get a question right by guessing, or because you just vaguely remember that answer C was the right choice for that specific question about Mrs. Jones, you have learned nothing. You've just fooled yourself.
So what's the better way? How do we actually hack the study process to make it stick?
You have to read the rationale, and here's the secret sauce. You need to spend more time reading the rationale for the incorrect answers, the distractors, than you do for the right one.
That seems counterintuitive. Why would I focus on the wrong stuff?
Because the wrong answer on your practice question today is going to be the right answer on the real exam next month. Let's say you have a scenario where you correctly prioritize airway over circulation. You get it right, great. But if you don't understand why, if you can't explain the physiology of why hypoxia kills faster than hypotension in that specific context, then you're vulnerable.
Vulnerable to what, exactly?
Vulnerable to the twist. The very next quotient might give you a circulation problem that is effectively an airway problem, like a massive hemothorax that's compressing the lung. If you just memorize the rule airway first, you're going to be confused. But if you read the rationale for the distractors, you would understand the nuance of gas exchange versus perfusion. You're building a mental model, not just a database of facts.
So it's about understanding the why behind every single option on the screen.
Precisely. And this ties right into cognitive load and how our brains work. The sources mention two big techniques: spaced repetition and active recall.
Spaced repetition is huge in learning science. The idea that your brain retains information much better when you review it in spaced out intervals, right? Like one day, then 3 days later, then a week later, instead of cramming it all in one night.
Exactly. And active recall is about testing yourself.
Right.
Don't just passively read your notes on ACE inhibitors and nod your head. That's too easy. Close the book. Force yourself to ask, okay, what are the 3 main side effects? That little struggle, that frustration you feel when you can't quite remember, that is literally the feeling of a new neural pathway getting stronger in your brain.
I saw a concept in the study guide that really caught my eye, the 80-20 rule, or the Pareto principle.
This is for every student out there who feels completely overwhelmed, which is basically everyone. The 80-20 rule says that 80% of the exam is going to be based on 20% of the material. You do not need to know the incubation period of some rare tropical disease found only in one part of the Amazon.
Thank goodness.
You need to master the high-yield topics: safety, infection control, Physiological integrity. That's your 20%. That gets you 80% of the points. Focus your energy on the lions, not the ants.
That's a perfect transition into the strategy of taking the test itself. We've talked about the logic, the CJMM, but what about the actual game plan? The sources highlight some specific frameworks for prioritization. These are the tools you need when you're stuck.
Right, and you will get stuck. That unfolding case study format is designed to be intimidating. You'll have 4 patients who all seem sick or 1 patient with 10 different problems. How do you choose what to do first? The absolute, unquestionable gold standard is the ABCs. Airway, breathing, circulation.
It sounds so simple, almost too basic for a high-level licensing exam.
It's simple to say, but the application can be really tricky. The hierarchy is rigid for a very good reason.
Yeah.
An airway obstruction always beats a breathing difficulty. A breathing difficulty always beats a circulation issue.
Can you give me a concrete example of how they test this? Because I feel like this is where students get tripped up on the nuance.
Okay, sure. A patient with shortness of breath gets oxygen before you sit down to discuss their coping strategies. That one's easy breathing beats psychosocial. But let's make it harder. What about a patient with a blood pressure of 82/50 versus a patient who is hyperventilating because of a panic attack?
Well, the hyperventilating patient looks like a breathing issue. They're gasping for air. It's dramatic.
It's dramatic, but it is not an oxygenation issue. Their airway is wide open. Their lungs are working just fine. The patient with the BP of 82/50 has a true circulation issue that is threatening to shut down their vital organs. Real circulation problems beat functional breathing problems every time.
So you really have to look past the label and think about the underlying physiology.
You have to. But wait, what if that circulation issue is chronic? That brings us to our next framework. Acute versus chronic, or unstable versus stable.
This feels like the tiebreaker.
It is absolutely the tiebreaker. An acute change beats a chronic condition every single time, even if that chronic condition looks really scary on paper.
Walk me through a comparison.
Okay, you have a patient with COPD. Their chart says history of COPD, and their O2 sat is 88%. To a layperson, that sounds terrifying.
88% is hypoxia for a healthy person.
Right. But for a patient with chronic COPD, 88% might be their baseline. Their body is compensated over years. It's chronic. It's stable for them. Now, compare them to a post-op patient, someone who's usually healthy, who suddenly has a blood pressure of 90/60 when they're normally 120/80.
That drop in BP is an acute change.
That's the unstable patient. The post-op patient is unstable. The COPD patient, even with a low O2, is stable. Even though 88% sounds worse than a BP of 90/60, it's the change that kills. You see the post-op patient first.
That's a huge pitfall, isn't it? Getting distracted by a dramatic-sounding history.
It's a massive pitfall. You see heart failure in the history and your brain just panics. But if that heart failure patient is sitting up in bed, eating Jell-O and chatting on the phone, they're not your priority over the patient who's developed new confusion.
New confusion, that's one of the biggest red flags you can see. It's the biggest. A sudden change in mental status is often the very first sign of hypoxia or sepsis, especially in the elderly. It is an acute neurological change, and that beats almost any chronic condition you can name.
And then, of course, there's Maslow. Maslow's hierarchy of needs.
A classic for a reason. Physiological needs, oxygen, fluids, nutrition, always come before safety needs. And safety needs always come before psychosocial needs, like love and belonging.
So if a patient is crying because they're anxious about their discharge instructions,
but their 5V is just infiltrated and their arm is swelling up, you fix the physiological problem, the swelling, before you address the psychosocial problem, which is the anxiety. It sounds harsh. We want to be compassionate nurses. But in the world of failure to rescue, you have to keep the body alive first so you can talk to them about their feelings later.
one of the strategist notes I found really interesting was about doing before assessing. The old mantra is always assess first. Don't just do something, stand there. Usually, that's right. And the exam often wants you to assess first. You don't call the doctor until you have the data. However, there is a deadly exception. If the act of assessing will delay a life-saving intervention, you act immediately.
Like choking.
Exactly. If a patient is choking, clutching their throat, you don't stop to assess their pulse oximetry. You don't get out your stethoscope to listen to their lung sounds. You do the Heimlich maneuver. Now, if a patient has no pulse, you don't waste time checking their blood pressure. You start chest compressions.
So the rule is to scan for those immediate life-ending threats first.
Yes. When you're in doubt or you're short on time, scan for red flags, sepsis, stroke signs. Form a worst-case hypothesis in your mind first. Ask yourself, if this is a stroke, what do I need to do? And if the answer is act right now or they lose brain function, then you act.
Let's shift gears now to the biggest section of the entire exam, the true heavyweight.
Safe and effective care environment.
The official breakdown says this category makes up about 25 to 37% of the exam. That's a massive chunk. You could ace every single pharmacology question, but if you fail this section, you fail the whole exam.
And it makes perfect sense when you think about it. You can be the smartest clinician in the world, you can diagnose a rare disease like Dr. House, but if you don't wash your hands and you give the entire unit MRSA, you are a danger to the public. And the board's job is to protect the public, not the nurse. This section is split into two parts: management of care and safety and infection control.
Let's drill down on safety and infection control first. You said it's the foundation.
It all starts with standard precautions, and that means hand hygiene. It is the single most effective way to prevent the spread of infection. The 5 moments of hand hygiene are gospel. You wash your hands before touching a patient, before a clean or aseptic procedure, after a body fluid exposure risk, after touching a patient, and after touching the patient's surroundings.
But where it gets really technical and where students lose a lot of points is on the specific isolation levels. This is one area where you just have to memorize the rules.
You have to know these cold. I always recommend mnemonics, but let's just break down the mechanics. Let's start with contact precautions.
Okay, this is for things that spread by touch, right?
Exactly. MRSA, C. diff, VRE. Think bugs you can touch. What do you need? A gown and gloves. And here's a key exam point. You must dedicate equipment to that room. The stethoscope you use on that patient stays in that room. The blood pressure cuff stays in that room. You do not carry it out to the next patient's room.
Okay, next up is droplet precautions.
This is for bugs that travel in heavy, wet droplets, things like influenza, pertussis, bacterial meningitis. These droplets are heavy, so gravity pulls them down to the ground after about 3 feet. So you need to wear a surgical mask if you're going to be within 3 feet of the patient. And the patient has to wear a mask if they leave the room.
And then there's the big one, airborne precautions.
The most dangerous ones: tuberculosis, measles, varicella, and now COVID-19, especially during aerosolizing procedures. These particles are tiny. They can float on dust motes for hours. They can drift right down the hall.
So a simple surgical mask isn't going to cut it.
No, not at all. You need a special N95 respirator that has been fit tested to your face. And crucially, the patient has to be in a negative pressure room. This is a special room that sucks air in from the hallway, so when you open the door, the germs don't float out.
I also want to touch on aseptic technique, specifically the difference between clean and sterile.
This is a critical distinction for safety. Clean, or medical asepsis, is about reducing the number of germs, like washing your hands or wiping down a bedside table. Sterile, or surgical asepsis, is about eliminating all microorganisms and their spores. Everything.
Like when you're inserting a Foley catheter.
That is the classic example. The human bladder is a sterile cavity. If you break sterile technique during that insertion, if your sterile glove accidentally touches the patient's leg or the tip of the catheter brushes the bed sheets, you have to stop. You throw the entire kit away, you get a new one, and you start all over.
In the moment, that must feel so wasteful and embarrassing.
It feels awful. But if you don't do it, you are basically injecting bacteria directly into the patient's bladder. That causes a CAUTI, a catheter-associated urinary tract infection. That is what we call a never event. The hospital does get reimbursed for it, and the patient suffers needlessly. On the exam, a break in sterile technique is an immediate safety fail.
Okay, let's move to the other half, management of care. Delegation is a huge, huge part of this. And it's tricky because in the real world, nurses are always helping each other out.
That's true. In the real world, the lines can get a little blurry. But on the NCLEX, those lines are concrete walls. You must know the scope of practice for each role.
What's the main rule to remember?
The rule is EAT, the letters EAT. An RN cannot delegate evaluation, assessment, or teaching.
So an LPN, a licensed practical nurse, or a UAP, an unlicensed assistive personnel, they can't do the initial admission assessment on a new patient.
Absolutely not.
Yeah.
Never. The RN must do that initial assessment because it establishes the patient's baseline. The RN must do the discharge teaching because that requires synthesizing the entire plan of care. And the RN must be the one to evaluate if the pain medication actually worked.
So what can an LPN do?
They can perform routine tasks on stable patients. They can give most oral medications. They can change a dressing on a well-healed wound. They can reinforce teaching that the RN has already delivered. But they cannot care for an unstable patient who requires constant judgment.
Let's run a quick scenario. You have a patient whose blood pressure is 80/50 and they need a dopamine drip to be titrated. And you have another patient, a stable diabetic, who just needs their routine insulin shot.
The RN takes the dopamine patient. That requires constant assessment and critical judgment. The LPN can take the stable diabetic. That is a routine medication administration on a predictable patient.
And the UAP, the nursing assistant.
They handle standard, unchanging procedures, taking vital signs, hygiene, feeding a patient, as long as there's no swallowing risk, and helping a stable patient ambulate. They do not assess. They do not teach. They can't ask a patient, "How is your pain?" and document that as an assessment. They can only report objective data, like the patient is crying.
It really feels like safety is the lens you have to look through for every single question on this test.
It is. Take something as simple as environmental safety, fall prevention.
Bed alarms, non-slip socks, keeping the bed in the low position.
It sounds so basic, but prioritization applies here too. Let's say you have a stable patient who wants to talk about their new cancer diagnosis.
Mm.
At the same time, you have a patient with dementia who is actively trying to climb out of bed.
The climber wins.
The climber wins immediately. That is an immediate physical safety risk. The conversation can wait 5 minutes. The fall cannot. A hip fracture in an elderly patient has an incredibly high mortality rate. Preventing that fall is life-saving care.
We should also quickly mention the 5 rights of medication administration.
Right patient, right medication, right dose, right route, and right time. It's a mantra we all learn. But on the exam, they're going to test you on the nuance.
How so?
Right patient isn't just about checking the room number. It's about checking the patient's wristband and asking them to state their full name and date of birth. 2 identifiers, always. And right time means understanding that insulin has to be timed precisely with meals, whereas a daily blood pressure pill has a much wider window.
Okay, wow. Dr. Alassi really packed this briefing. We've gone through the logic of the CJMM, the strategy of using rationales, the frameworks for prioritization, and the hard rules of safety. It's a lot to take in.
It is a lot.
Yeah.
But just remember the mission. We are bridging that gap. We're trying to get you to think like the nurse you want to become.
So let's try to recap the biggest takeaways. We've shifted from that old linear ADPIE model to the new cyclical 6-step CJMM. Recognize cues, analyze cues, prioritize hypotheses, generate solutions, take action, and evaluate outcomes.
And it's a loop. It's a constant cycle. To navigate that loop, you have to prioritize using your tools. ABCs, Maslow, and acute versus chronic. And the way you study for it is by understanding the why, the rationale behind every single answer option, especially the wrong ones.
And you can never, ever forget that safety is the absolute bottom line. Infection control, fall prevention, these aren't just little boxes you check off on a list. They are fundamentally how you keep your patient alive.
Exactly. If you are safe, you are more than halfway there.
I want to leave our listeners with one final thought to chew on. We talked about how the exam simulates reality, but on the exam, you answer question 15, you get it right or wrong, and you move on to question 16. It's finished.
But in the real world, it is never finished.
Right? So consider the idea that clinical judgment is never truly done. In practice, that evaluate outcomes, step number 6, immediately becomes the recognize cues step for your very next decision. The cycle never, ever stops.
And that's the provocative thought, isn't it? If the cycle never stops, how does that change the way you walk into a patient's room tomorrow? You aren't just there to complete a task and leave. You are entering a continuous, unending loop of observation and decision-making. You are always detecting. You are always analyzing.
And that is the true difference between a task doer and a professional nurse.
And that is how you master the licensure exam and, far more importantly, the career that follows.
Thank you for diving so deep with us today. This is the kind of preparation that builds real confidence. Good luck with your studies, and remember, think like a nurse.
And stay safe out there.